Hi, Dave.
Hello, how are you?
Hi, I'm fine, thanks.
Good, good.
Okay, so welcome everyone to the TRT and Hormone Optimization YouTube channel. Dave is back with us to answer all your TRT related questions.
Good to be
But
back.
before we start, Dave, tell us what's going on. You started the TRT Academy. What's that?
I did. Yeah, I started the TRT Academy as a evolution of my private Facebook group, which has been running for a little while now, for a place that I can upload, I guess, all my I kind of call it like group coaching. It's everything that I'd like to say to all my clients all in one place. And then the advantage of using the school platform is that it doesn't get suppressed by the Facebook algorithm, because I was having 900 people in my group, but when I did a post, it would only go to 50, 60 people. And a lot of them were paying to be a part of the group. So it was quite frustrating. Facebook was also censoring what I could say, but it also gives me a platform that I can build some courses and build some unique content. So my friend Tom from Marek Health is also running it with me, as well as our friend Ali Gilbert. So that's the project that I'm going to be working on over the next 6 months. And if anyone wants to join, you can do so via my website. It's on there, as well as my new FAQ, which is a free download with the 12 most frequently asked questions about TRT that I've ever received. And all of our recommended providers, pretty much everyone from this group, plus a few others, are in the back as well. So people can download that for free from my site too. So I've been busy.
Awesome. And what about the new clinic you joined to service the part of Europe with the TRT?
Yeah, yeah. So this one is in the final stages before it's going live. So we're putting the finishing touches on the website and getting everything ready to go. But TRT Baltic is going to be servicing Eastern Europe and Scandinavia, and then we're going to be opening additional European countries as we go. It's very exciting for us to be able to service Europe, because in this part of the world, as you well know, it is extremely difficult to get access to treatment. And this allows us to not only get access to treatment, but get access to all the best quality treatments that we talk about on this channel, things like the 20% compounded transcranial cream. And ideally, what we're going to be working on is for all the guys, particularly in Scandinavian countries, who at the moment have to travel every 3 months or 6 months to get their prescriptions filled. Ideally, we're going to be able to service everyone remotely. So that's our goal, is to be able to bring these treatments to the part of the world where it's virtually impossible to get access to treatment, because so many guys are having to use underground products to source their treatments at the moment, which is not ideal. So that's going to be up and running, hopefully within the month.
Awesome. Great news for a lot of guys. Yeah, thank you.
Yeah.
All right, so we've already got a bit of questions in the chat box there. I don't know if you're able to read them as well. But before I take those questions, I had another question from a friend of mine who's already using a compounded 20% testosterone cream for a long time. And now he saw a video on Balance My Hormones YouTube channel. You know them, and it was about the 10% DHT liposomal cream. And he asked if it would be interesting to add that next to the TRT cream. What's your opinion on that?
I've been trialing this personally. I've just finished up using it for a couple of months. I wanted to trial it myself before I made any comments or recommendations on it. What I found was that adding any amount of additional DHT cream to the existing 20% transcranial testosterone cream I was using induced low estrogen side effects. It hurt my joints quite profoundly. And I tried, different dosing, one click a day up to four clicks a day, adjusting the baseline testosterone dose to be able to accommodate more DHT. I think you get so much DHT conversion already from the transcranial cream that it's just not necessary, and it pushes that equation, I think, into an unfavorable direction. I think that if there was going to be potential use for the DHT cream, it could be used topically after a period of PFS where there is actually damage to the vascular network in the penis. The studies on DHT cream topically at the moment, the only one that's been done topically on the penis was regarding micropenises during development to help achieve proper growth with that. So I think theoretically it may help and apply to guys who've had PFS. But I think if anyone was going to use it, it would be more beneficial to add it to a injectable testosterone protocol, because the amount of DHT that we're already getting via the transscrotal cream, I think, is already well beyond what we need. So I haven't found it to be too useful. And I think if people are wanting to optimize their cream protocol, and I'm just going to give a shout out to Keith here because this 100% came from him. He shared with me a huge catalog of data from the HRT base of cream. I think if people aren't using the HRT base and they're using the liposomal, I think swapping over to the HRT base of cream is what's going to make the biggest difference. It's also a much more natural, gentle cream, less preservatives in it as well. People are even apparently using it just as a moisturizer without any actual hormones in it because it's such a good cream. So I think if people want to optimize their cream protocol, it would be looking at swapping to the HRT base.
Yeah, well, I asked Nicolas Psatas from NP Labs about it, and it would take 3 months to get an HRT base.
I'm hoping that with the clinic that I'm setting up, that we will have such a high demand for it that we will make it worthwhile for him to have it available all the time. Because the liposomal cream is great. I mean, we probably both use the same liposomal product from NP Labs. I've just found that some guys need 3-4 clicks twice a day to get a optimal level of testosterone. I remember when I reviewed your blood work a while back and we did the video, publicly about it. A lot of guys are needing double that dose that you're using to get those levels with the liposomal, but then when they use the HRT base, they don't need that. Okay. Keith showed me some fantastic results where guys were getting astronomical numbers and having to reduce to just 1 click twice a day to get into that sweet spot that we like to sit in. So, hopefully that's something that they're going to make readily available, because I think that we're going to have quite a big demand for it for them.
Awesome. Okay, let's go to the chat box, and I'll first go to Joshua Stam, since he's a member of the channel. He says, I've just been prescribed recombinant HCG. Urine HCG was causing low blood sugar. Any experience using recombinant HCG versus UHCG on patients?
No. Theoretically, this is something that I looked at a little while ago, because the different types of growth hormone can sometimes produce an autoimmune response in some people. And theoretically, the negative side effects that that some people get from HCG could be coming from an autoimmune reaction to some component of it. So I did play with the idea of looking at that, but sourcing that in Australia and in Europe is just, getting regular HCG is hard enough. Yeah. So I wish I had a better answer for that, but I do think that the side effects from HCG are because it is inherently estrogenic. And I think that's what causes the feminizing or anti-masculine side effects a lot of guys get from HCG. That's just my personal opinion. And it's a hypothesis because we don't have a hard answer on it. And I think that that's open to conjecture and interpretation. And it's great to hear other people's insights. But no, I don't have any knowledge or experience on that. But it's interesting.
Yeah. Then I'll go back to the start there. If I purchase a 10 milliliter vial of T-cypionate for my TRT, it would last me about 4 months. On a weekly dose of 125 per week. Would the rubber stopper and the testosterone be good within that time frame?
Yeah, definitely. The rubber stopper, when it comes to pharmaceutical testosterone expiring, breaking down over time, it's not something that's going to sour and go off like milk would. It's something that would arguably lose potency, or potentially it could hypothetically lose sterility, I guess. But the real issue that guys are going to have with long-term storage of testosterone cypionate, if they're not following the advice that we talk about in this group, is using too big of a needle to punch a hole in the top and compromising the airtight nature of the vial. Doing that over and over again could cause issues. But yeah, if someone's going through a 10 mil vial of testosterone using 125 milligrams per week, no way are they going to have an issue with that rubber stopper breaking down. That would take multiple months, potentially multiple years to occur. So no, not a concern.
He also writes, I read that the carrier all can dissolve the rubber stopper over time. Plus, if I use ampules, perhaps I can preload syringes. How would the storage process work in those scenarios?
I guess the only hypothetical problem for breaking down the rubber stopper would be if you stored the testosterone upside down. So it was constantly pushing against the stopper, which I don't know why you would do that. The stopper wouldn't be touching the testosterone because of the air at the top. So I don't think that would be an issue unless it was potentially laying down for very long periods of time. I do wonder if, and I mean this very respectfully to the original poster, if these kind of questions are manifestations of anxiety. When it comes to storing testosterone in syringes, a lot of guys do this, particularly in Australia, because they're using the Bayer preloaded Primatestin syringes, which I guess a bit more convenient than ampules because you can cap them. But the problem with ampules is once you crack it open, you've got a whole mill that is essentially become non-sterile instantly. And a lot of guys will have the solution of storing this in insulin syringes to then use for their next injections. I strongly advise against doing this because this is what will break the rubber stopper down in the syringes. If that's what he's referring to, that's a real problem. I may have misinterpreted the question. If that's the concern, very real concern. I've seen guys do this and send me photos because they'll unknowingly do it if they're like going away for a week or going away for 2 weeks. They'll just, for some reason, they don't want to take their vial, so they'll preload a bunch of syringes. And you can see by the end of it, the oil becomes discolored in the syringe because that preservative is, yes, breaking down the rubber stopper. And potentially it's also breaking down the wall lining of the syringe. So you'd be injecting plastics and all kinds of crap into the body. Insulin syringes are not, like, I know that there's a bunch of clinics in the States that are selling like preloaded insulin syringes of other stuff as well. This is like, definitely don't do this. Maybe overnight, 24 hours, you could get away with it, but I couldn't think of a situation in which that would be necessary. If you're using ampules, it's even not advised that people do this because as soon as you crack the ampule, it's not sterile. So even if you draw and then inject it into a vial, that has the potential to cause an infection. But if people are going to store testosterone after cracking an ampule, which most people will because they're not going to be pinning a whole ampule at once, because we talk about why that's not a good idea. The only way that you can do this, and it's still not recommended, but it's the best option of all of them, is you have to transfer it into a sterile vial. Sterile vials are easy to get. A pharmacy should be able to order one in for you. You shouldn't even have to find one online. You should be able to buy one from a pharmacy, but it needs to be transferred into a sterile vial. Yes, it's cumbersome to draw and inject and load and so forth, but that's why we don't really recommend ampules. A lot of the guys in the UK will use Sustanon because the ampules are real cheap. I guess if that's worth your time to do, then that might be a good option. But that's the downside of ampules. But yeah, don't store testosterone in insulin syringes.
Sure. Wolf here, he's 20, 5'8", 142 pounds, I guess. I sleep for 8 to 9 hours. I still feel energyless every time I wake up. No morning wood for the past year. I don't even remember when I had my last one. Libido is also extremely low. Started to go to the gym for past 6 months, calculated diet, yet gained majority fat, only decided to get my test levels. Got to know I have extremely low levels, 180 nanograms per deciliter. What advice would you give me?
Okay, so if he wasn't so light, I would be saying, so if people are going to extrapolate this out for their own learning, in a scenario like this for anyone else, it's very important to not just look at testosterone, but also look at the thyroid, because low testosterone symptoms and low thyroid symptoms are basically the same in men. The whole, you have to have cold extremities thing for thyroid, not really the primary symptom that we see when it's mild and subclinical. A lot of the time it's this just fatigue, lethargy, anhedonic kind of stuff that we see with low testosterone. Now, given this guy is quite light, but I mean, he did also say that he's calculated his diet and he's putting on fat. The most important thing that this guy can do, and I sound like a broken record saying this because it's the only real answer to a lot of these questions where guys are looking for very personal, here are my stats, here's my bloods, what should I do? The first thing you have to do is get a more comprehensive lab panel, because a good provider will want to assess everything: thyroid, adrenal hormones, obviously your full androgen panel as well. Things like your liver, your kidneys, your lipids, your red blood cells, white blood cells, your diet, your lifestyle. all of this stuff is really important in determining what's going on. The most important thing, well, not the most important thing, but one of the most important things that this gentleman could do is have a provider assess where his gonadotropins are. So if his luteinizing hormone is suppressed, like a 2 or under, he could have a cause of low testosterone that he can resolve without needing to go on TRT. But if he's got, mid-range gonadotropins or even elevated gonadotropins suggesting damage to the gonads, then he's going to want to get those testosterone levels up, because those are terribly low levels for a man of any age, especially a young man. And it would be virtually impossible for someone to thrive and feel good on those levels. So if he's applying himself, he's doing everything right, it's very important that he sits down with a provider who can go through everything, but also give him a recommendation that's going to be based on what's in his best interest, not based on what they want to sell him or what kind of, ulterior motive they might have, to be able to give a recommendation. But this is something that he absolutely needs to get thoroughly investigated. But the most important thing for anyone in this kind of scenario is to have everything investigated at once, because I often see guys in these scenarios who've got fatty liver disease, they've got Hashimoto's, hypothyroidism, they've got just massive issues with diet and lifestyle. They're following something like a vegan diet, or they're doing something that's just not conducive to their health, that they don't really understand what's wrong. So this needs to be further investigated and absolutely resolved, and it may require TRT.
Yeah, sure. John Minky, I can't tolerate daily Cialis. What do you think about salt palmetto for hair loss and BPH?
I don't like the idea of inhibiting DHT, period. This would definitely be a better question for Jordan Grant. So when it comes to daily Cialis, a lot of guys don't tolerate it, whether it's for BPH or for erectile dysfunction. A lot of guys don't tolerate a lot of pharmaceuticals. So why some guys don't tolerate Cialis? Some guys just need to take it with more water. Some guys need to take a lower dose, like 2.5 milligrams a day. But there are still guys, and there's plenty of guys out there who simply don't tolerate it. They have very different mechanisms of action for supporting the prostate, and saw palmetto is a natural DHT inhibitor. And I think that anything that inhibits DHT should be avoided like the absolute plague, for a myriad of reasons. The one thing that people often don't talk about is that 5-alpha reductase is not just responsible for making DHT and making allopregnenolone. It's also responsible for metabolizing cortisol. So when someone blocks 5-alpha reductase, whether it's with finasteride, dutasteride, minoxidil blocks 5-alpha reductase, whether people like it or not, they can look up the studies on it, or using saw palmetto, you're basically attempting to solve one problem, but you're creating multiple other problems in its place. And all of these are problems. So it's a poor trade-off. I would reassess the scenario and look at alternative treatments, because it sounds like neither of those options are good for him. And I am not a prostate specialist, so that would be a question for a urologist for sure.
An add-on question that just came in: should you cycle Cialis?
That's a good question. It depends what you're using it for. So I've written a couple of times about my thoughts on Cialis. I think that ultimately the goal, especially for a younger man, if a man's in his late 60s or 70s and so forth, different story. But if we're talking about a young guy here, if a young guy is using Cialis for erectile dysfunction, we ultimately want to resolve the need for that. So I think the long-term goal should be not to require Cialis for sexual function. However, what we all know is that the sexual benefits of TRT take time to kick in. 6 months, 12 months, potentially longer if a guy's health is particularly derailed. It might take him, 12 to 24 months to resolve things like insulin resistance, excess body fat, improving his cardiovascular health, improving his mental confidence, all of those kind of things, having a good sexual relationship with his partner. All of those things take time. So Cialis can be a good thing that can work as a band-aid in the interim, especially if the lack of sexual function is burdening or stressing the relationship. If someone's married or living with a partner and their inability to maintain an erection is causing strain on the relationship. I think daily Cialis for the first X months of treatment, typically 3 to 6 months, is a fantastic way to fast track those benefits to be able to have those more holistic benefits around intimacy. And what I find a lot of the time is that once guys get to the 3 to 6 month mark, they just forget to take it. They just go, oh, I don't need this anymore. And then it just works out of their system. The only dependence risk of Cialis is a psychological dependence, that people think that they can't perform without it. It doesn't cause a physiological dependence, but most people will attest in practice that I think it's kind of like caffeine. If you don't drink coffee ever and then you have a coffee, it's going to hit you a lot harder than it would if you were taking it daily, but it still has the effect that it should be producing daily. So if people want to get the most bang for their buck out of Cialis for like, a one night performance, then yeah, taking it without using it regularly does in practice yield a stronger effect. But it doesn't mean that using it daily is subject to some kind of massive tolerance or it stops working. So I don't think it needs to be cycled. And I think if Cialis is needed for erection function, the dose can be put up. 5 milligrams of Cialis is not very much. Cialis is well studied in 20 or even 40 milligram doses a day. So if guys do have legitimate erectile dysfunction while they're waiting for their testosterone dose to kick in, and the 5 milligrams of Cialis isn't cutting the mustard, 10 milligrams of Cialis a day is a very reasonable dose to use. And additional things can be used in conjunction, like things like citrulline. I think guys should be focusing on, cardiovascular health, reducing stress, stuff like that. But the dose can be escalated of it while it's needed. But yeah, so I don't think it needs to be cycled. I think it more needs to be looked at as I'm using this for a period until I no longer need it.
Yeah. How is the pre-test total test ratio calculated? I understand it should be about 3%. Unit conversion required.
Yeah, so it's difficult to answer questions like this because there's different units used all over the world. I mean, in Europe, there's different units used from country to country. It's when you're consulting international clients, it's an absolute nightmare. Sometimes they even print the units wrong. So if you're in Europe and you're looking at your blood test and it doesn't look right, sometimes they actually print the wrong units. It happens more often than people would think. So it's not so much how is the ratio calculated or what should the ratio be. Free testosterone is calculated based on your SHBG and your albumin. Albumin tends to stay more constant. Albumin's typically measured as part of a liver panel. So albumin doesn't vary that much unless you've got like liver disease, but SHBG varies a huge amount person to person. So depending on where your SHBG sits will depend on your ratio of total to free testosterone. And having a very high or a very low SHBG can be pathological. I have a very simple way of stating this. If SHBG's got one number or three numbers, you might have a problem. If it's between 10 and 99, it's probably fine. Now, if you're a younger guy and you've got an SHBG of 95, then of course, then that could be suggesting something too. But as a general rule of thumb, there's a very broad goalpost that SHBG sits within based on genetics. The two things, or the handful of things, sorry, that I see influence SHBG either up or down that people should be aware of. One is that hypothyroidism and insulin resistance will often lower SHBG, and that's something that should be assessed as part of a comprehensive review anyway. But that can be a red flag that those things need to be looked at. So maybe if someone's got, a borderline thyroid panel and they've got an SHBG that's very low, that would warrant, looking into running Hashimoto's antibodies, but I think people should just test them anyway. And one thing that increases SHBG a lot, which a lot of people don't look at, is SSRI antidepressants, 5-alpha reductase inhibitors, vegetarian and vegan diets. So vegetarian and vegan diets will increase SHBG without increasing total testosterone, which leads to a lower free testosterone ratio. So there are also being in ketosis long term or being in deep caloric restriction long term will raise it too as part of the body's survival adaptation. So when it comes to SHBG, it's important to recognize that genetics are a big factor. There can be pathologies leading it to be high or low, but what's going to determine an individual's free to total testosterone ratio is primarily going to be based on their SHBG.
Is there a relationship between TRT and low potassium?
between TRT and low potassium.
TRT and low potassium, yeah.
There could be, but if there is, I'm not aware of it. To kind of answer and give some insights around electrolytes, though, there's absolutely a relationship between TRT and magnesium. TRT will deplete magnesium at a faster rate because testosterone depletes magnesium as part of its metabolism cycle. So the higher your testosterone is, the higher your requirement for magnesium. I think that the higher your testosterone is, the higher your requirements for a lot of nutrients are. And I think it's very important that if a man wants to optimize and increase his testosterone up to the healthiest physiological level he could possibly have, he also needs to provide himself with the best quality nutrition and fuel across a broad range of micronutrients. So I would be looking at all electrolytes. There are some great trace mineral supplements that you can get, but I think that particularly if someone's predisposed to anxiety and they train a lot, I would look at magnesium before looking at other things, because a lot of people, I don't think the argument that everyone's deficient in magnesium is evidence-based. I think that that's very good marketing from people who sell magnesium. But I do think that if someone is looking to supplement with electrolytes, I think on TRT, especially if they train a lot, magnesium is a good place to start. Glycinate or biglycinate is the best option because it's the most tolerated in higher doses. And a lot of guys do get maximal benefits from magnesium glycinate at higher doses than 400 milligrams a day, sometimes looking at 300 to 500 milligrams twice a day. But if they use other forms like citrate, that will result in a laxative effect, magnesium citrate, make you shit. So it's important to use magnesium glycinate if we're going to be pushing the dose up more than 400 milligrams a day.
I'm going to, because a lot of questions are coming in, I'm not sure we can take every question, but I'll give Joshua Stam again the advantage because he's a member. For patients who get anxiety when starting TRT, does the wired feeling or anxiety fade after a few months?
Okay, I like this question. So it's going to massively depend on the individual, but does it fade? Yes. Does it fade down to nothing? It depends on if the individual has underlying issues with anxiety. So testosterone is not a stimulant per se. It doesn't fall into the category that would identify it as a stimulant, but it stimulates the central nervous system, especially when someone is naive to the dosing. So when the body gets an acute spike in testosterone, whether they're initiating TRT or when guys are doing cycles of anabolics, for example, it causes more activation of the central nervous system. The problem is that if someone is predisposed to anxiety, what feels like activation will then lead to an anxiety response. I use the analogy that, and it's a, in the sport of boxing, it doesn't make any sense why these two people would be fighting. But if you took two boxers, one who'd won every fight and one who'd lost every fight, and they went into the boxing ring together, as they're walking out and the music's playing, they're both going to have the same physiological sensations of anticipation, which is butterflies in the stomach, shortness of breath, elevated heart rate, all of that stuff that's very normal. But the guy who's won every fight will associate that with victory and excitement and, positive anticipation. Whereas the guy who's lost every fight will associate that with failure, pain, losing, embarrassment, humiliation. But physiologically, they're the same. So if someone is predisposed towards anxious thinking and has an anxious thought process, then this is definitely going to be something that is going to potentially be uncomfortable for that first few months of treatment. So the things that I find that are very helpful for that period, CBD oil works very well. We often recommend it for my clinic in Australia. Magnesium works well. Phosphatidylserine works well. I've done lectures on all these supplements on the channel. Those ones work really well, as well as if people are drinking coffee or caffeine, combining it with theanine can help to take the edge off. But this can also potentially, if it doesn't fade and resolve, be an indicator that the dose is too high. So it is very important that the individual gets that blood test at about 8 to 12 weeks when the provider orders the first blood test, I would hope, which is when levels reach a stable concentration to make sure that the dose is correct. And sometimes guys who are more prone to anxiety, because sometimes testosterone helps with anxiety, sometimes it makes it worse. And it depends on, where it's all coming from. But sometimes guys who are feeling like cranked and like wired, like, jacked up in a bad way, Sometimes they do better starting with the dose a little bit lower and then titrating it up very gradually every 3 to 4 months rather than shooting straight for a higher level because their nervous system and their psychology needs time to adjust. So yes, it does back off once your body gets used to it, assuming the dose is correct, but a baseline anxiety state can be exacerbated by higher androgen levels. And that's why it's also important that the root cause of the anxiety is addressed. I like things like mindfulness meditation, martial arts, stretching and mobility. All of these things really help, as well as looking at different forms of cognitive behavioral therapy, how we think and how we look at things. And sometimes it actually helps for guys to speak to a therapist, which I know gets a bad rap, but sometimes it is helpful. So it's important to look at it holistically.
Jason Cook says, my doctor increased my T cream dose from 60 milligrams, 1 pump in the AM and PM to 1 pump in the AM and 2 pumps in the PM. Question, is evening better for testosterone absorption?
So he was previously taking 60 and 60, and now he's taking 60 and 120. Is that right?
60 and 120, yeah.
Yeah. So you could kind of argue either way in terms of mechanistic theory, but in practice, because sometimes when it comes to cream adjustments, ideally we want to be looking at an even dose AM PM, but if we're making small adjustments, depending on what dispenser is available, because in a lot of countries we don't have toppy clicks, so we can only adjust cream in increments of what would be 2 clicks, which would be half a mil. So sometimes we have to have a higher dose in either the morning or the evening to get a reasonable dose adjustment, because doubling both would sometimes be too much. I would argue, and I think almost every practitioner in this group would argue, and I don't want to speak out of turn, but I think everyone would agree that if one of the AM or PM doses is going to be higher, it should be the morning dose. And that's because the testosterone is going to be more activating. That's more in alignment with the circadian rhythm. It's more in alignment with where the hormones naturally peak. And again, a higher dose of testosterone doesn't always cause sleep disturbances at night, but with the increased conversion to DHT that comes with transscrotal cream, that is more likely going to lend to favorable outcomes during wakeful hours than sleep hours. So is the absorption greater at night? No. Like you're rubbing it on your balls twice a day, it's going to absorb the same anyway. So I would be looking at doing it the inverse, having the higher dose in the morning and then the lower dose in the evening if they're going to be out of balance. It just makes more biological sense that way, and I also see that work way better in practice.
Sure. Is TRT okay for someone with atrial fibrillation?
Definitely a individual question, because it depends on what's causing the AFib. Anyone with an underlying issue of cardiovascular disease absolutely needs very specialized care and monitoring when it comes to initiation of treatment. I think anyone who's going on treatment, because the thing is, testosterone, low testosterone is not good for AFib, and testosterone is cardioprotective, but it also needs to be done in the right context, under the right supervision, with the right protocols. I think anyone who's got a history of cardiovascular disease should be employing the start low, go slow mentality when it comes to initiating treatment, because rushing to a higher dose and kind of like what we spoke about before, cranking the nervous system up from a rapidly increased level of testosterone, that volatile level, and also the body having to rebalance things like aldosterone, things like mineral balance, things like water retention, all that kind of stuff. If you've got underlying cardiovascular issues, that's potentially opening up risk factors. So I don't think testosterone is contraindicated for someone with AFib, absolutely not, but it warrants more close specialized care. And it's very important that if they are going to do that other measures to support cardiovascular health are very well taken care of.
What do you think? What do you say to those clinics that advocate the dutasteride to crush DHT? Is DHT detrimental to longevity?
What would I say to those clinics? Fuck it. Like that's what I'd say. Like, I guess each to their own, but that's my opinion. I would be happy to debate anyone on this channel live with no preparation about why we shouldn't be crushing DHT. I guess it's a subject for argument and discussion, but I mean, anyone who understands the role of 5-alpha reductase, not just DHT, would understand the importance of not suppressing it, especially into the ground with something like oral dutasteride. So I think that adding dutasteride to TRT not only massively increases the risk of side effects, because when you block DHT, you massively upregulate conversion to aromatase. And it's important that these enzymes in the body are functioning naturally and keeping themselves in homeostasis. Just like, blocking DHT is not good, just like blocking estrogen is not good. We need both of them in balance. And I think that guys who, and I've said this before, and it's of course someone's going to make the comment that it's two bald guys talking about this, but we're not the ones who are sacrificing our health because we're insecure about how pretty our haircut is that if people are knowingly going to risk sacrificing their long-term health to keep their haircut, you don't need to be enabled. You need to speak to someone about that, because that's a very concerning indication of self-esteem and where you're seeking validation from. I think that's something that needs to be looked at quite seriously. So these clinics, I mean, unfortunately, clinics are going to do whatever they want, and upselling multiple medications is always going to be appealing. But consider that DHT is by far the strongest androgen in your body, and if your goal is to increase androgen activity via testosterone replacement therapy, this is literally shooting yourself in the foot. But the thing that guys really need to be conscious of when it comes to post-finasteride syndrome, which it falls into dutasteride as well, this is not something that we know how to fix. There are treatments for it that do work for some guys, and a lot of guys improve, but a lot of guys only get back to 80, 90%. And plenty of guys, I've met plenty of guys who are still recovering and they're optimistic, but there's not like a treatment that we can go, oh, if you get PFS, take this and it will fix it. This is a unknown. And this is something that, people, if people don't believe me on this, you can search up the Reuters article for the lawsuit against the manufacturers of this drug, who knowingly suppressed the information regarding the side effects that occurred in the clinical trial. They knew about PFS when they were developing the drug. They just didn't mention it because they knew it would hurt sales of the drug. They literally said that in court for the class action they lost. So, guys who are still defending this medication, like, I don't know what to say to people. You can take whatever you want, but for guys who are looking at getting optimal hormone replacement therapy care and looking to improve their hormone levels, taking dutasteride or finasteride is literally the last thing that you want to do.
Yeah. I recently quit drinking my 2 to 3 beers each night based on me learning that it will inhibit TRT. Will drinking or not affect just how I feel, or perhaps will it affect my testosterone numbers as well?
Great to hear. If anyone watching this is a member of the TRT Academy or has been following me on my Instagram or any of my private work, I am vehemently against alcohol consumption because I see what it does to bloods, and I see what it does to people's health. Through the clinic that I partner with in Australia, and before people whinge in the comments about me not being a doctor, as a health coach, I review about 30 to 50 sets of bloods per day, per week, in addition to my usual private consult. So I see a lot of blood work, but I see a lot of reviews that we do at the 12 to 16 week mark and the 6-month mark on treatment. And the number one thing that causes guys to not achieve the expectations they have of TRT is regular alcohol consumption. And there's a huge cohort of men who don't understand, because of culture practices or their own biases, or for whatever reason, that you can't drink 2 to 3 beers a night or 10 to 12 beers on the weekend and be healthy. Now, there can be an exception to the rule. You might say, well, I know this guy who drinks like that and he doesn't have it. Cool. Exceptions don't disprove rules. That's not how science works. But for the vast majority of guys, alcohol consumption is the number one thing holding back their TRT that is so easy to fix. I mean, losing 10, 20, 30 kilos of body fat, that's difficult. Not picking up a beer bottle and going like this is much easier. So it's an easy thing to stop and it's an easy thing to cut out. And the there was a study that came out recently, Rhonda Patrick referenced it, where it showed that basically lifetime consumption of standard drinks equated in terms of negative outcomes on mortality as cigarettes. So one beer is as bad as one cigarette for your overall health. So alcohol's terrible. And I think that everyone is so much better off not drinking any alcohol. I think the best approach if people do want to drink alcohol is to have 1 to 2 drinks on a special occasion. Friday night is not a special occasion. And if people are going to be, you know, for the guys who are like red wine connoisseurs or whiskey connoisseurs or craft beer connoisseurs, I think the absolute maximum you can look at drinking is 1 to 2 drinks, 1 to 2 times per week, but you'd be significantly better off with 0 or at the lower end of that. And for guys who are going to insist on continuing to drink, I think you should take glutathione. But to answer this guy's question, he is going to be much better off without it. His entire body is going to function much better without it. It's not going to impact his testosterone numbers. Well, I mean, if he was drinking 2 or 3 beers a night, it could be impacting his liver's ability to metabolize the ester. So it could impact his numbers depending on what his individual alcohol tolerance was. But for the most part, it will reduce his C-reactive protein. It will reduce his LDL. It will reduce his triglycerides. It will generally reduce AST and ALT. It will reduce blood pressure. It will reduce hematocrit and hemoglobin. And it will increase his overall sleep quality, his well-being, his IGF-1 levels will all increase. So blood moves in very favorable directions when people stop drinking like this. And 2 to 3 drinks a night is a lot of alcohol. Like over the course of a week, that's a lot of alcohol.
Yeah, well, it's easy, Dave, to say when you don't drink at all, but I have also a lot of patients in my practice who think it's very normal to have 1 drink a day, 2 drinks a day. A lot of people think that's just normal, socially accepted. So.
Yes, and that this casual alcoholism is one of the most challenging things for guys to unlearn when they get on TRT, because I see guys all the time who are spending hundreds of dollars a month on gut supplements. I mean, if you're having gut issues and you're drinking alcohol, don't worry about the gut supplements. Just stop drinking booze and it will get way better. But I see guys who are biohacking and eating super clean and working really hard on their diets, and then they're binge drinking on a Friday night, or they're drinking a couple of drinks every night, and they don't realize that they're completely derailing all the hard work they're doing, and it's just not worth it. The buzz and the intoxication that people get from alcohol, not only is it very mild relative to the damage they're doing, but it makes you feel like shit the next day. And if people are drinking like this and you stop drinking for a couple of weeks, take a photo before and after, and your face will look noticeably less bloated.
I've heard this question before, but what could cause the acne spike when switching from injections to cream with similar testosterone effects?
So people who are predisposed to getting acne will often get a increase in acne, I guess, outbreaks or occurrence, whatever the correct term for that is, because when DHT increases rapidly, it will increase the production of sebum. And this will essentially, I mean, you can correct if I'm wrong here, but this will cause if it dysregulates the amount of sebum that the body is usually making, the pore is more prone to getting clogged, which will lead to acne. So it's hormone fluctuations that are problematic. It's why women will be predisposed to acne around their cycle. It's not necessarily where the hormones are, it's the changing in hormones. So change will induce this for guys who are predisposed to it. And I understand that it sucks. I've been very, I guess, blessed that I've never really dealt with acne my whole life personally. So it's something that, you know, I'm very grateful for that. But, you know, especially when guys get it very bad on their face or on their upper body and it scars, it can be quite distressing. And, you know, looking at what they can do to support their diet, support their liver health, support their hydration, you know, removing things that are inflammatory to the gut can often be really helpful. And the biggest thing that I've seen help a lot in Australia in terms of just what's, you know, common with the guys who I work with is if you wear like a polyester like shirt and you sweat into it at work, that can be quite, you know, that can annoy the skin quite a bit. So getting like a cotton undershirt if you sweat into a polyester work uniform, or if you're wearing polyester like active wear to the gym, getting rid of that can be really helpful too.
Mm. Should I worry about getting on TRT with hereditary hemochromatosis? I get rose every 8 weeks to keep ferritin between 50 and 100. Hematocrit is always around 17.5.
So arguably, increasing testosterone will be therapeutic for hemochromatosis because it will reduce ferritin levels in everyone. So this gentleman, it would be important if he's regularly getting phlebotomies, every 8 weeks. He might find that if he goes on testosterone and continues that schedule, if that brings him into a 50 to 100 range for ferritin, that could make him anemic because testosterone will increase red blood cell production by utilizing more ferritin. So I find that when guys have like half the hemochromatosis genes, like when they've only got one SNP for it and they don't have the full-blown presentation, a lot of the time TRT will resolve their need to phlebotomize. So it can be very therapeutic for hemochromatosis. But if someone's got full-blown hemochromatosis, it's not contraindicated, but it's something that will likely change their requirement for blood donation. And that needs to be monitored to both make sure that it doesn't get too high or too low. I have seen guys over phlebotomize on TRT all the time, and it leads to anemic symptoms, which is basically nulls and voids the benefits of their TRT treatment. So every 8 weeks is a very high frequency for phlebotomies. So I would be testing levels before getting a phlebotomy done after initiating TRT to make sure that levels aren't going to get tanked. And you might find that you can push that frequency back to maybe every 10 weeks, 12 weeks, 16 weeks, depending on, where that individual's levels sit.
Mm-hmm. Special question from Chris there. I can only rate my progesterone via pregnenolone when I microdose aromatase. Any reason why?
He can only what, sorry?
He can only raise his progesterone via pregnenolone when taking microdosing aromatase.
He can only increase his progesterone. Okay, I can see it. Can only raise my progesterone via pregnenolone when I microdose of aromatase. Any reason why? This is a very individualized question with no data. I mean, that's impossible for me to answer accurately. In terms of theories around that, it doesn't make any sense because pregnenolone's conversion to progesterone is not mediated via aromatase, and there's not really any secondary actions of the metabolites of aromatase that would encourage that pathway to function that it wouldn't otherwise function. So potentially this individual is not tolerating pregnenolone without the aromatase inhibition. And this would suggest, and I've seen this all the time, is the progesterone lab range for men is often ridiculous. Like a lot of the time it's telling you that it should basically be 0, or it's telling you that it should be 10 times higher than it should be. Progesterone in men should be very low, but detectable. So, but with that said, sometimes the cutoff for where progesterone can be measured is quite high. So sometimes men will have very healthy levels of progesterone, but the lab range will say it's undetectable. So if this individual is not tolerating pregnenolone without aromatase to try to increase progesterone, it sounds like he is self-diagnosing and trying to tweak his own bloods blindly. I use the analogy of he's popped the bonnet on his car and he's just tweaking with things to try to fix the problem. See a provider, work out what your negative symptoms are, get a good baseline because you might be barking up the complete wrong tree. And if you require aromatase to tolerate the benefits of pregnenolone, then that means that I would say that you're definitely barking up the wrong tree, or there's other medications in the mix which are causing issues. But from a conversion standpoint, doesn't make any sense. From a tolerability standpoint, you likely don't need pregnenolone and you're trying to solve your stress-related symptoms, which I talk about in the Beyond TRT lecture. It's very common for guys to try to solve their stress problems with pregnenolone because it's such an anti-stress, pro-GABA hormone, but it will inherently lead to anti-androgenic side effects if it's not needed.
Is he writes it. If 5-alpha reductase is suppressed, would Proviron help to upregulate its disposal?
So I actually did a podcast with a guy named Ryan from Cortex Labs, and we spoke about some of the interesting impacts of Proviron itself on hormone pathways, and the fact that in the literature it does suggest that it can modulate and increase 5-alpha reductase activity. So theoretically, mechanistically, it seems that when you add in either DHT derivatives or bioidentical DHT, it not only facilitates the end result of the 5-alpha reductase pathway in the androgen cascade, but it also seems to promote more production of the enzyme itself. This is why DHT cream is a very promising adjunct treatment for post-finasteride syndrome. So it's a plausible thing to look at. Now, when it comes to Proviron is infinitely inferior to bioidentical DHT because it's a non-bioidentical analog of DHT. So I would be, again, taking a step back here and going, if someone needs augmentation of the DHT pathway for whatever reason, a lot of the time it's due to SSRIs, post-finasteride syndrome, obesity, insulin resistance, chronic pain, which is causing elevated prolactin, chronic stress, all of these things. Starting with a transscrotal testosterone cream is a better way to do that because we're using more bioidentical processes and we're facilitating the body doing what it should be doing with the least amount of intervention. So I would be looking at a transscrotal cream first, as opposed to adding Proviron to injectable testosterone, because you'll be able to most likely net a similar outcome by facilitating the body doing that via its own natural processes.
Mm-hmm. I have another question for you, Dave, because I also asked the same thing to Jordan. If you recommend someone starting on the testosterone cream, what's the typical frequency you recommend? You start out once a day, twice a day, all the pumps in the morning. What's your typical startup protocol with the cream?
If we've got TopiClicks and we can dose it in increments of 0.25 mil, 1 to 2 clicks twice a day. If someone is particularly old or particularly obese or in a particularly poor state of health and their baseline testosterone levels in the gutter, sometimes I think it's best to start with 1 click twice a day to bring them from here to here. And then after 12 to 16 weeks, if needed, we can take them from here to here. I don't see any reason why they have to go from here to here, especially if they are predisposed to developing side effects. If someone's symptomatic at a relatively higher free testosterone level, then going to 1 click twice a day might only take them from here to here. So it depends on where their baseline is and how much we want to increase it by. In Australia, where we only have the 0.5 mil increments, so it's like 2 clicks at a time, in those circumstances, I would just recommend people start with 1 click in the morning and then, one pump in the morning. And then if we have to increase the dose after that, then we add the second pump in the evening. But Keith says it very well. The most important benefit of, or the most important variable to focus on when optimizing cream is stability, and that's best achieved by twice daily dosing. I think you can do cream once a day, but I think it's always going to be more beneficial to do it twice a day. But if a guy sleeps naked with his wife, and that's an important part of their intimacy, then I think if that's something that he doesn't want to lose or something that he doesn't want to interrupt, I think that that's a very reasonable thing to go with a once morning application. So transference via intimacy is a real factor with this. And if that's something that's going to be something new to adjust to, or it's a complicating factor, then it absolutely can all be done once in the morning. But yeah, 1 to 2 clicks twice a day, depending on the individual, where their blood work is, their baseline state of health, would be what I'd recommend starting with.
Mm-hmm. Okay, so let's take the last one as the last one there. Is there an optimal T to E2 ratio? My provider seems to think guys do best at 3 to 5% range. I'm currently around 7% with minor libido issues.
I think that there probably is an optimal ratio, but I think the ratio is very broad, and I think it encompasses a very wide range of numbers. And that ratio is going to self-regulate for men who are healthy. The issue that guys are having when it comes to libido is a very multifactorial, volatile, and often influenced by things outside of biology. It can be impacted by the relationship. It can be impacted by confidence. It can be impacted by work stresses, so many different things. So sometimes it's very normal for guys to not have much of libido, regardless of where their hormones are at, because of their circumstances. So that's something that guys just need to wrap their head around, is that testosterone replacement therapy is not just going to be a bulletproof vest to give them a 16-year-old's libido all the time. So when it comes to what the optimal estrogen level is, it's something that should, if an individual is healthy, self-regulate. The factors that impact aromatase are things like T3, insulin, prolactin, cortisol. And if there are factors that are dysregulating those parameters, then estrogen will become dysregulated. The problem, though, is that estrogen is an anti-inflammatory hormone. It's a protective hormone. So in all of those circumstances, estrogen's the fire engine. It's not the fire. We don't want to get rid of the fire engine. We want to put the fire out. So it's not estrogen's fault per se. Estrogen is like the smoke alarm going off. We need to work out what the problem is and address it. So, but with that said, I have not found that estrogen levels correlate with estrogen symptoms. In the context of TRT, at least. Now, if someone's estrogen is like astronomically through the roof, like, 200 or 300 or something like that, yeah, okay, different story. But for the most part, for 99.9% of guys on TRT, estrogen should settle where it's supposed to settle, because we can't measure things like receptor availability, the ratio between alpha and beta receptors, all of that kind of stuff we can't measure. So there's not a optimal estrogen ratio, but if someone is troubleshooting their TRT, they need to look at all the blood work overall, because a lot of the time there's, like if there's libido issues, there can be a DHEA deficiency, they can be hypothyroid, they can be chronically stressed, they can have other factors leading to, deficiency. They could be on SSRI antidepressants. There are so many factors that these guys don't disclose when they're troubleshooting these things, or their providers don't look at. So just trying to manipulate testosterone and estrogen to solve a man's problems, we have seen how this plays out. It's why this group exists. It doesn't work.
All right. So thank you so much for taking the time to do this Q&A, Dave. If people want to reach out to you, how can they best reach you?
Yeah, so people can reach me on Instagram. I'm Dave Lee. You can also just tag me in the in the TRT and hormone optimization group. It's the only Facebook group that I am moderating, and I moderate it as much as I possibly can. So please tag me in the comments so that I can see it. We get a lot of posts, so I don't see everything. And if people, want to work with me more closely, Advanced Fundamental Health is my website. If you land on the website, you'll get a pop-up to download my free FAQ, which just came out, and you can reach out to me through there if things like consultations or anything like that are relevant. There's also a couple of cheap ebooks on there that can help guys out with a lot of these questions as well.
Awesome. Thank you so much again, Dave, and enjoy the rest of your weekends.
Thank you. You too, and we'll chat soon. Thank you.
Thanks. Bye, man.
Bye.
Bye.